Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of November 11th, 2024. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. The goal of the People's Health Briefing is to equip you with the best knowledge and insights to keep you, your loved ones, and your community as safe as possible. Since the last People's Health Briefing, a lot has happened. Following the elections, I think we're all wondering what changes might be ahead. So I wanted to spend some time today on some of the key things I think are top of mind as it relates to public health. And there are honestly so many things that I could talk about. It was actually really difficult to narrow it down. We have major threats to individual and public health that we're very concerned about, from reproductive health to mental health to gun violence. Today, I'm going to focus on the big concerns as it relates to some of our contagious illness threats. And even narrowing that down is challenging because we have significant concerns related to things like antibiotic resistance and not enough new medications in the pipeline, and also increases in sexually transmitted infections and other things. So as usual, no shortage of topics to discuss, but let's go ahead and get started with where we are with COVID-19. Starting with SARS-CoV-2 in the wastewater nationwide, we can see that concentrations are low and they're coming down in pretty much every area except for the Midwest, which you can see more easily if we hone in on the last 45 days. So that yellow line seems to be heading up just a little bit. So we'll keep an eye on that. But definitely, if you want to know what's going on in your area, you'll need to take a look at a resource like the Wastewater SCAN map, which is linked in the post, and you can see if there are any wastewater sites reporting near you. Next, we'll take a look at emergency department visits and deaths with diagnosed COVID-19. We're still not getting very much reporting on hospitalizations, so I will just report on emergency department and deaths until we get something a little bit more reliable there. Hopefully we will get that soon, as it became required reporting starting November 1st. But in the meantime, I'm glad to see emergency department visits with COVID continue to come down. Also glad to see that we're finally under 1,000 deaths per week for pretty much so far the month of October, hoping that trend continues. We'll expect that it will continue into November, and hopefully a little bit beyond that too, because we're seeing that wastewater and emergency department visits are down. We know that that is an earlier indicator, and then the deaths lag behind. So we do have other things definitely circulating around like right now, like colds and adenovirus and so on. Flu is actually off to a pretty slow start, which is good news. And we are having a decent little reprieve here from SARS-CoV-2, which we know gave us quite a lot of trouble over the summertime. So we need a little break here. Of course, we expect it to go back up again during the holidays with all of the traveling and mixing indoors that we know goes on. Because even though we know that SARS-CoV-2 is not seasonal, we have seen that the spread is very closely related to our behavior. And I've noticed that not everyone likes to hear this, because in some ways it is just easier to say, well, it's so contagious, there's nothing we can do about it. But the truth is that our actions can definitely lead to greater spread and to outbreaks and to super spreaders. So, of course, in turn, that means that we can also reduce all of these things with our actions. Our actions can reduce transmission. Our actions can reduce household spread. Tough, but doable. Our actions can reduce outbreaks and super spreader events. And our actions can prevent poor outcomes. So we cannot 100% prevent all of these things, but we absolutely can reduce them. And remember that reducing the spread can save lives of more vulnerable people. It can reduce or limit the number of infections or reinfections that you get, which I think very clearly needs to be a goal. The more we learn about the cumulative effects of repeat COVID infection, the more we have to acknowledge that reducing the number of reinfections is a good goal. And also remember, every infection is another opportunity for not only a bad outcome, but also is another opportunity for long COVID, something that millions of people are struggling with already, and more people are coming down with every single day. So when I say actions, yes, I am talking about individual actions like the ones we talk about here all the time, about getting vaccinated and wearing masks and gathering outside. But I'm also talking about really making a concerted effort as a society to do what clearly we see needs to be done to clean our indoor air. To me, this is no different than that point in history in time when we realized that many diseases were being spread through contaminated water. So we made the investments in our infrastructure that needed to be done in order to ensure clean drinking water. And over the last few years, it has become abundantly clear that we need to do the same thing with our indoor air, and we should not delay this any longer. And we should not just leave this up to individuals. We need leadership, we need guidance, and we need investments to ensure that our indoor environments are conducive to learning, conducive to working, and not conducive to the spread of pathogens. We also know that our actions can prevent many of the hospitalizations and deaths that we are seeing with COVID. And so even though we might brag about having all the tools, the fact is that not enough people are able to access these tools. And oftentimes that is through no fault of their own. Unfortunately, many medical providers still seem to not be properly informed or properly advising their patients about the importance of prescribing or taking antiviral treatments for those at risk of a bad outcome. We're also still seeing terrible disparities, not only in COVID outcomes, but even in interventions. So what do I mean by that? I'll just briefly remind us of this important study that was done this past January. I covered it in a prior briefing, which is linked in the post, but I think it was an important one to remind us of how we need to be vigilant if our tools are going to make the difference that we think they should be making. So this was a study published in JAMA in January 2024, clinical risk and outpatient therapy utilization for COVID-19 in the Medicare population. This was focusing in on 2022 at Medicare enrollees, and it was looking at outpatient treatment. So that was at that time Paxlovid, molnupiravir, and monoclonal antibodies. And they looked across a number of different patient characteristics like age and race, ethnicity, whether they lived in a nursing home, and whether they are also eligible for Medicaid, which is, of course, for low-income folks. And unfortunately, we saw everything that we don't want to see, namely that those people who are at highest risk for bad COVID outcomes like hospitalization and death were least likely to be prescribed outpatient antiviral treatment. So Black and Hispanic patients, low income patients, adults 80 and up, people living in nursing homes, all of these groups were less likely to get outpatient COVID-19 treatments. And those who were on Medicaid, so those are low-income patients, were especially unlikely to receive treatment. So this is really an indictment. We try to declare things that we've beat them or that we figure them out. And we see, this is not the first time we've seen this, where we get the tools and then we start to see disparities get wider because those who have good access can get the tools and those who don't have good access cannot. And this, in this case, means more hospitalizations and more deaths that could have been avoided. So we have a lot of work to do. We need to do a better job of actually getting treatment to those who need it. And we should all do what we can to avoid this happening to ourselves or to loved ones. Work with your doctor, work with your family members to work with their doctors to come up with a treatment plan in advance and advocate for yourself and for your loved ones, because unfortunately that is the situation that we are in. So unfortunately, we still have significant disparities in health outcomes, significant disparities in access, even in the United States, let alone the rest of the world. So we need a concerted effort in order to overcome what is really a legacy. It's historical, and it is also our current reality, even with a pathogen that is new. And so to do this, it would take a real acknowledgement that this is in fact our reality, and it would take a real commitment. It would take an investment to properly address this issue, these issues. And this means that we would need leadership that prioritizes the well-being of all and acknowledges that with some groups, we have a lot more work to do. Part of the problem is, of course, an inadequate safety net. Not all states in the United States have expanded Medicaid for low-income people, which is just mind-boggling. And even those places that do have expanded Medicaid access to actual doctors who take Medicaid can really be a challenge. And in a country as wealthy as the United States, I do not think it's too much to ask that we regard healthcare as a basic right, just as we have kindergarten through 12th grade education as a basic right, we should have healthcare as a basic right. And during the public health emergency, we actually got to kind of see what it looks like to have some health services be free and be low barrier for everyone. And honestly, it was an amazing thing to witness and to be part of. The way that we scaled up to serve such a high volume of people at one time, I had really hoped that that would be something we could build upon instead of dismantle at our first opportunity. Unfortunately, that was not the choice we made, but hopefully some of the positive things will be able to continue. It looks like some of them will, such as access through telehealth services, but there is still so much more to be done to ensure access and to ensure equitable outcomes for everybody. The next issue that is top of mind is our preparedness for the next pandemic, along with the safety and security of our food supply. And I think that many would agree that these things are certainly related, especially highlighted by the H5N1 situation that we are finding ourselves in. And by way of a quick update there, Canada recently identified its first case in this outbreak. And so, of course, it's concerning that it has gone from the United States to Canada. It's even more concerning, I think, that this patient is a teenager and that they are hospitalized. They're not certain at this point where the teenager got H5N1, but it does bring about concern that this has been spreading undetected, since we really aren't clear on where or how this teenager actually contracted H5N1. But certainly hearing that the teenager is hospitalized is definitely bringing up some concerns about the severity and what is going on there. So we will certainly be keeping an eye out for more information on this. But I will reiterate here what I think is a key concern, especially in this moment. There is no single unified food safety agency. And there is no federal agency that has the authority to test for human diseases on farms and feedlots. So as it relates to H5N1, which we all agree has pandemic potential, it seems that it is no one's job specifically to contain the spread. We have too many different bureaucracies, too many different agencies kind of patchworking around what is a significant threat, and we do not seem to have a unified response or clarity regarding who is accountable, who is in charge. The USDA regulates meat and eggs and poultry and promotes U.S. agriculture. The FDA focuses on food safety under Health and Human Services. And the CDC focuses on human infection, but it doesn't have direct authority to test workers. So this is a rather frightening example of where we need more coordination and more oversight, not less. So I think we are bracing ourselves for what is to come. We know that there was an Office of Pandemic Preparedness and Response established in July of 2023, which Mr. Trump did vow to dismantle. So we'll just have to see what actually happens from here. So we've talked about improving infrastructure for improved indoor air. We've talked about health disparities. We've talked about the safety net, talked about pandemic preparedness and improved accountability. And all of these things will require solid leadership. They will require investment. And we will need to be paying attention to all of what is continuing with the SARS-CoV-2 pandemic. And we will need to address the long COVID crisis that is also simultaneously happening. And that will also take focus and investment and acknowledgement that this is happening. But I would probably argue that the biggest threat we are facing right now to the public health, to the health of the public, has to do with what I'll call low public health literacy coupled with low trust. So too many folks don't know what they don't know. They don't know who to trust, and they are consuming information from disreputable sources. And this is an area where, as much as I'd like to think we should be able to look towards government and agency leaders, that just might not be a realistic expectation based on all that we have experienced over the past few years and that we continue to experience. And I am beginning to feel more and more like it is up to the field, those of us in science and health and medicine, to do more to earn trust, to build trust, to hold ourselves accountable, to hold each other accountable. And this was already a big area of interest of mine, and that's why we do the People's Health Briefing now, and it's why we have really formed in the first place. That's why Roots exists in the first place, actually, was because we acknowledge that we have a lot of work to help overcome all of the distrust in medicine. And so we need to be trying to do this as a top priority because health is really a two-way relationship and is not working for everyone. But even the situation that we were in before seems to have gotten worse over the past few years. It seems to have actually taken a major backslide in a very public way, basically since the onset of the pandemic. And it's kind of ironic and a little bit bewildering because it's really amazing all the things we've been able to achieve in such a short time. So many innovations, so many tools, like I said, but at the same time, we are watching a real backslide in terms of some of the most basic things. And we know that this is likely a response to several things happening all at once, a lot of politicization, a lot of different narratives that are going on, but also really, I think, an abdication of duty in many different places that I think we're going to have to get a hold of if we want to mitigate some of this backsliding. So you might have seen this recent headline, which really should be mortifying to us all. So specifically, there is a regional public health department in Idaho. It comprises 6 different counties. And their public health board recently voted to no longer provide COVID vaccines to residents of those 6 counties. And so it's important to point out that one of the key essential functions of a public health department is to vaccinate people in their jurisdiction. This was before the pandemic. This is just one of the key functions, and particularly those who are very vulnerable, those who rely on the safety net that I've been talking about. So back to that discussion of the importance of investing in our safety net. Public health departments are often responsible for vaccinating those who are homeless, those who live in nursing homes, those who live in shelters, and really keeping track of where vaccination rates are dipping and intervening in order to try to address that. And this helps to not only keep those vulnerable folks safe and keep those settings safe, but it also reduces the risk of serious outbreaks and threats to the health of the public more broadly. And this also includes institutions like jails and hospitals, nursing home shelters, like I said. So we've seen how the politics around COVID and the COVID vaccine have played out. But public health departments should not be basing their policies and their practices on politics. It should be based on the morbidity and the mortality, and it should be based on carrying out essential duties of a public health jurisdiction. And we have already seen some states like Texas and Florida kind of decline to recommend the COVID-19 vaccine, which also has not been science-based in any way. It's been very obviously politically motivated. But the situation in Idaho appears to be the first time that the vaccine has been stopped altogether. Super concerning and hopefully not precedent setting, but that's of course the concern. Now, people with their own doctors and with their own means can get the vaccine other ways, but those who rely on the public health department will be out of luck. Fortunately, community health centers should still have the vaccine. So for folks who are living in that area who've been relying on the public health department, they should be advised to check in with a local community health center. But again, I think what's most alarming here is really the possible precedent. Just the fact that this choice would even be allowable when we know that unfortunately communicable diseases don't stop at the edge of a county or a state. They don't adhere to borders. And so decisions like this can have an impact far greater than just the individuals who can no longer access the vaccine. And I'm sure it's no coincidence that Idaho has some of the lowest vaccination coverage rates, even for just routine childhood vaccines. Less than 80% of their residents have received MMR, the measles, mumps, rubella coverage. And in fact, that same region of Idaho battled a measles outbreak last year. And frankly, they're just asking for more to come when their coverage rate has dropped so low that is now below the threshold that will be needed to prevent onward spread. They also have the lowest coverage of the DTaP vaccine, so maybe they might expect some pertussis outbreaks. Very contagious, especially when you have very low coverage. Their polio vaccine coverage is also the lowest in the country at only 80%. Once again, if a polio case gets brought in, let's say by a traveler, someone coming in who's been traveling in another country to one of these neighborhoods with low vaccine coverage, we could again see cases of polio in the United States. Absolutely foolish. Idaho also has some of the highest rates of vaccine exemptions. And so I went over this in some detail a couple of weeks ago. I've linked that prior briefing in the post, as well as the morbidity and mortality weekly report that it was based on, in case you want to check out those details. But here are some of the highlights. Vaccine coverage declined to under 93% for all reported vaccines in 2023, 2024. 127,000 kindergartners were exempt from one or more vaccines. The vast majority of these are belief exemptions, so very few medical exemptions, but these are just a choice. And they really have increased in most places, so 40 states and DC. And exemptions for one or more vaccines increased to 3.3%. From 3% from the year before, and 14 states, one of them being Idaho, reported exemptions over 5%. So all very concerning, and really just points to the fact that despite all of our great technology and innovation and wonderful science, we're actually going backwards on some very, very basic things. And I think we're at risk of continuing to go backwards and going to a place where we haven't seen since the pre-vaccine days. So we would be really foolish to get ourselves into that situation. And so we really have our work cut out for us. And as individuals, maybe we can't control all of these things, but there definitely are a number of things that we can at least try to control for ourselves and in our environments, in our households and community. And with the holidays coming up, this is a great time to think about exercising caution and doing our part to keep from spreading sickness over the holidays to family and loved ones especially, but really if you're traveling, then really to anyone. So if you're planning to gather over the Thanksgiving holiday, consider masking up for at least 10 days before your gathering. And if everyone that was going to be going to the gathering agreed to do this, it would go a long way to prevent an outbreak at the gathering. And for anyone who has experienced outbreaks at gatherings, it can really just alter the memory of the occasion for the worse, particularly if it leads to any severe outcomes in any of the guests. Consider pre-event testing so that you don't have anyone positive actually attending the function. You can provide the test for the guests, or you can get folks to agree to test before they come over. You'd be surprised at how amenable a lot of people are to doing some of these simple things just for the comfort and safety of everyone involved. Definitely do what you can to improve ventilation at your gathering, opening up windows and having air filters and so forth. If you're going to be traveling, please mask up. Don't let COVID be your wingman. Mask up in the airport, on the airplane, in the bus, on the train, in the public bathrooms. In the scheme of things, it's a pretty small inconvenience compared to the benefits, the protection you can basically afford to yourself and those around you. If you haven't yet gotten your 24-25 vaccine, now would be a great time to do that. And you'd be nice and protected from actually getting COVID for a few months after getting the vaccine. So remember, the main reason we're taking the vaccine is to prevent against severe outcomes. We also know that right after you get it, you do have a bump in protection from actually getting and spreading COVID. So not 100%, again, reduction, but if you're going to be doing a lot of traveling in November, December, and we know that that's a time when transmission tends to increase, people tend to gather more indoors, there's a lot more traveling and gathering, like we're saying, then getting that vaccination now, if you haven't already gotten it, will maximize your protection over those months. And just to make sure that everyone is aware of the updated guidelines from the CDC's Advisory Committee on Immunization Practices, it's now recommended that anyone 65 and up get the vaccine every 6 months. So you get the new one when it comes out and then 6 months later. And anyone 6 months and up with a moderate or severe immunocompromising condition, same thing. So we see in the new guidelines a lot of reference to shared clinical decision-making, and that means you're having this conversation with your doctor, with your primary care provider. And if for any reason your doctor is not following guidelines, you really deserve a good understanding of why. You want to make sure it's based on science, not politics, not being tired of COVID, not feelings or vibes, but actual science. There's just too much overwhelming evidence of the protection that we get from vaccination from severe outcomes, particularly those at risk, which includes a lot of people. It's not only 65 and up, it's not only immunocompromising conditions, it's people who are pregnant, it is our babies. Remember, we've had quite a lot of morbidity, emergency department visits, and so on in that under 1-year-old group in particular, but also just in the under 5 age group. And we know that a lot of those children are not being properly protected. So there really isn't any science-based argument against it. And especially in the higher risk groups, very much like the annual flu shot. There's really just too much evidence that it helps, and there's just too much morbidity and mortality still from COVID. We're just losing too many people, too many hospitalizations, and we know that a lot of that can be prevented with at least an annual vaccine, maybe twice a year. It seems like a lot. And I can't wait for a better vaccine strategy, but right now this is the best one that we've got. And the link to the updated guidelines is in the post if you want to check it out. So in the meantime, of course, we will be keeping an eye on how all of this is going to be unfolding in the coming months and years. Please direct message us or email us at admin@rootscommunityhealth.org if there's any topics you would like to see us cover in particular. And in the meantime, if you don't have a primary care provider, please get one, establish a relationship with them, get your blood pressure and your baseline labs checked, like cholesterol and blood sugar, get the appropriate cancer screenings for your age and risk factors, know where you stand. And remember to eat a balanced diet, incorporate fresh foods, avoid sugary drinks and processed foods, get some regular physical activity. Unless you don't feel well, in that case, please do get your rest. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.